Hello, everyone. Thank you for joining us. Welcome to the Avexia webinar series. Our topic for today is CVMap, Advanced Diagnostics for Patients at Risk for Cardiovascular Disease. My name is Christopher Chu. I'm the Director of Marketing for Avexia Diagnostics and will be your host for this webinar. Today, I have the distinct pleasure of being joined by an exciting guest, Dr. Andrea Girman, who will be our presenter for this webinar. Dr. Girman is a graduate of Johns Hopkins University School of Medicine, Pediatric Residency Program, and Bloomberg School of Public Health, as well as the Beth Israel Medical Center, Continuum Center for Health and Healing Integrative Medicine Fellowship. As founder of Communitas Consulting LLC, Dr. Girman currently offers executive leadership, content development, and project management services to clients in the diagnostics, health optimization, and preventative medicine arenas. Without further delay, I will now turn the webinar over to Dr. Girman.
Hello, all. This is Andrea Girman, a consultant working with Boston Heart Diagnostics, and I'm happy to be here for this Avexia Diagnostics webinar on Boston Heart's new foundational panel, CVMap. In this webinar, we'll be discussing why clinicians just like you are now choosing advanced cardiovascular labs for patients who are concerned about or who might have an existing history of cardiovascular disease. We'll consider populations at risk for CVD, as well as the limitations of standard lipid screening, and then transition to an exploration of the CVMap product, what it is, who it might benefit, and what reporting looks like before finally taking a closer look at some of its individual components and their clinical utility. So let's dive in. First up, why advanced diagnostics? Now, you all likely know that despite significant reductions in mortality rates over the past few decades, cardiovascular disease remains the leading cause of mortality for both men and women in the U.S., with morbidity and mortality resulting from underlying coronary heart disease, cerebrovascular disease, peripheral vascular disease, and/or heart failure. According to the American College of Cardiology and the American Heart Association, major CVD risk factors include increased age, male sex, though the risk gap between men and women narrows with menopause, ethnicity, underlying medical conditions such as hyperlipidemia, hypertension, diabetes, and obesity, and modifiable lifestyle factors such as smoking and physical inactivity. In addition, emergent data suggest risks may be associated with gut microbiome alterations, inadequate vitamin D status, and disrupted sleep, both quality and quantity. Finally, despite an overall decline in CVD mortality rates over the past 2 decades, persistent rates of high CVD risk remain in select populations, as well as in individuals living in geographic areas that are rural or marked by low socioeconomic status. This graphic of mortality rates per 100,000 in women on the top row and men, the bottom row, underscores the point just mentioned. Between 1990 and 2019, just over 25 million persons died of cardiovascular diseases, a stunning statistic. Moving from left to right across rows, you'll note differences in coloration for non-Hispanic Black, Hispanic of any race, and non-Hispanic white populations. The lowest rates of CVD mortality are represented by blue coloration, with increasing rates indicated by yellow coloration and highest rates indicated by red coloration. As you can see, the highest prevalence of high CVD risk individuals was noted among non-Hispanic Black males. Efforts are clearly needed to reduce both CVD burden and disparities in these populations and geographies. Given U.S. CVD statistics, screening via lipid diagnostics has become a cornerstone of clinical practice, yet standard lipid tests have limitations. We know that 50% of patients presenting with an MI have normal levels of LDL-C, and that there are common genetic mutations that drive CVD risk without impacting LDL-C levels. Data suggests that there are more robust markers of CVD risk that are not included in standard lipid panels. As an example, markers that provide insight into the level of inflammation in the body, which is a key driver of CVD development. And finally, residual risk for CVD can persist even when the primary intervention target, decreasing LDL-C levels, is met. Now, atherosclerosis is a key feature of cardiovascular disease development, and this image highlights the relationship between its pathophysiology and clinical symptom. It's a chronic inflammatory process that begins with damage to the endothelial lining, progressing as atherogenic particles such as small, dense LDL and lipoprotein A enter the vessel wall at sites of damage where they are oxidized. Cholesterol-laden foam cells then infiltrate the arterial wall, resulting in the earliest hallmark of developing plaque, the fatty streak, as well as release of pro-inflammatory cytokines, free radicals, and enzymes that foster plaque enlargement. As the process of lipid deposition and inflammation continues and the size of the established plaque increases, the plaque can become unstable, making it more vulnerable to rupture. Given that the average age of heart attack in the US is around 64 years for men and 70 years for women, the key clinical question is, how might we catch the development of CVD while it is still subclinical, years before the MI occurs? The answer lies in using all the tools in our toolbox, including clinical history for risk factors and diagnostics that allow for earlier detection and intervention, so that we can support patients at the earliest stages of cardiovascular disease, what studies suggest may be at least 20 years before progression to severity that results in heart attack. Now, there are a variety of tools that can be used in clinical practice to determine a patient's CVD risk. One of the most accurate is the MESA Risk Score Calculator, which combines standard risk components with a CT coronary calcium score to calculate a patient's 10-year coronary heart disease risk. While the ACC and AHA guidelines favor the universal use of statins in conjunction with lifestyle adjustments in all high-risk subjects and for primary prevention where a patient's global risk exceeds 7.5% in 10 years, others advocate for intervening in anyone with an even lower 10-year CVD risk of greater than 5%, especially when advanced diagnostic biomarkers such as small, dense LDL-C indicate higher risk. With all of this in mind, let's turn our attention now to exploring the CVMap profile. So what is the CVMap? The CVMap profile is Boston Heart's foundational panel for screening, monitoring, and guiding intervention in patients with or at increased risk for or concerned about their risk for cardiovascular disease. It's been designed to provide a more comprehensive insight into CVD risk by combining standard lipid markers with state-of-the-art lipid, lipoprotein, inflammatory, and lipid particle number markers. When considering patients in your clinical practice who might benefit from the CVMap profile, consider those who currently have a history of CVD or who have been estimated to be at increased risk for CVD. As noted here, these include patients being managed for cardiometabolic issues, for hypertension, for cerebrovascular disease, for a familial history of CVD, and those who have significant lifestyle risk factors. As mentioned earlier, Boston Heart designed the CVMap profile to be a foundational diagnostic panel that could be easily incorporated into clinical practice. And the complete offering of biomarkers available on the test are noted here. To increase clinical insight into a patient's risk for cardiovascular disease, CVMap provides a standard lipid biomarker panel and then complements it with advanced lipid markers like SD-LDL-C, apolipoprotein B, and lipoprotein A, as well as lipid ratios, key markers of inflammation, NMR particle size analysis, and a proprietary Boston Heart test, cholesterol balance. We'll be looking at these markers in more depth in just a bit. CVMap reporting is as follows. Page 1 of the CVMap report has been designed to provide the busy clinician with an immediate visual sense of patient's risk for each biomarker using a green, yellow, and red schematic. Results in the optimal range are highlighted in green. Those in the borderline range are highlighted in yellow, and those indicative of increasing risk are highlighted in red. As an example, let's look at reporting for total cholesterol. You'll notice two lines dedicated to total cholesterol. The first line provides the patient's result, here reporting a level of 230, which places the patient in the yellow or borderline risk range. And the second line, which provides Boston Heart's cutoffs or reference ranges for the optimal, borderline, and increased risk categories. In this example, both lines are highlighted in yellow, indicating the borderline risk category into which this patient's results fall. Page 2 provides another summary of all patient results from page 1, and any follow-up testing done for this patient will also be reported on page 2, providing an opportunity for the clinician and patient to see trends and results after a therapeutic intervention. Pages 3 and 4, when needed, provide a high-level treatment consideration summary for biomarkers in the borderline or high-risk categories. And page 4 also provides pertinent notes related to the biomarker technology platform or result interpretation. Let's turn our attention now to the individual components of the CVMap profile, beginning with standard lipid biomarkers. Current standard of care lipid panels typically include total cholesterol, calculated LDL-C, HDL-C, and triglycerides. And while these markers are valuable for providing basic insights into CVD risk, as mentioned, they are limited in several ways. In these next slides, we'll explore some key takeaways for the select standard lipid markers featured in this particular section. Now, as you know, LDL-C is the primary target for CVD prevention, and guidelines emphasize achieving recommended LDL-C levels to reduce events like MI, stroke, peripheral artery disease, and sudden cardiac death, as well as hypertension and type 2 diabetes. While other lipid abnormalities noted on standard screening lipid profiles like HDL-C and triglycerides are also important, LDL-C remains the main focus for prevention. Given that having the most accurate assessment of LDL-C levels is important, and direct measurement provides an optimal foundation for initial measurement and monitoring post-therapeutic intervention. LDL-C levels respond well to both statin therapies and lifestyle modification. Can too much HDL-C be too much of a good thing? The answer is yes. We know that lower levels of HDL-C are independently associated with risk of cardiovascular disease, and that higher levels of HDL are considered protective. Yet some studies suggest that HDL levels greater than 100 milligrams per deciliter can have a negative health impact, with increased risk for liver disease, inflammation, and potentially increased risk for mortality, especially in individuals with underlying liver and autoimmune diseases and with metabolic syndrome, in adults less than 50 years of age, and also in postmenopausal women. Lifestyle modification and use of statin meds, especially Crestor, as well as fish oil, have all been shown to support increasing HDL levels. Non-HDL-C is a measurement of all blood cholesterol particles except for HDL cholesterol, and this includes levels of chylomicron remnants, LDL, VLDL, and intermediate density lipoprotein cholesterols, as well as lipoprotein A. Data suggests that non-HDL cholesterol may provide a better prediction of CVD risk than either total cholesterol or LDL-C alone, especially when triglycerides are high and the LDL-C value does not accurately reflect circulating atherogenic particle amounts. Interestingly, the HA recommends that non-HDL levels be measured at least once every 5 years in adults greater than 20 years of age, and more frequently in individuals with CVD risk factors such as hypertension, diabetes, and a history of smoking. Elevated non-HDL-C levels respond to lifestyle modification practices as well as pharmaceutical interventions appropriate for the patient's clinical history. Let's take a look now at CVMap's advanced lipid and apolipoprotein biomarkers. We'll begin by looking at two featured biomarkers on CVMap, small dense LDL-C and very low density lipoprotein cholesterol, or VLDL-C. In 2021, published data from the prospective Framingham Offspring study indicated that small dense LDL-C was the most atherogenic lipoprotein parameter amongst all reviewed for the development of atherosclerotic cardiovascular disease, or ASCVD. Bolstering this finding was data published in 2023 from the Pooling Project, which was a pooled analysis of nearly 16,000 individuals who had participated in the Framingham Offspring, ARIC, and MESA studies. Its goal was to assess the 10-year prospective CVD risk in all subjects. Researchers found that having a direct SD LDL-C level greater than or equal to 50 milligrams per deciliter was a significant independent ASCVD risk enhancer. Elevated levels of SD-LDL-C have been shown to respond to pharmaceuticals such as statins, fibrates, and nicotinic acid. In the Jupiter trial, treatment with rosuvastatin at 20 mg per day not only decreased LDL-C and HS-CRP levels, but also decreased SD-LDL-C levels by greater than 50%. Finally, nutritional strategies underscore the importance of reducing simple carbohydrates such as fructose due to their potential for increasing synthesis of SD-LDL-C subclasses. Very low density lipoprotein cholesterol is essentially the amount of cholesterol carried by very low density lipoproteins as they carry triglycerides and cholesterol from the liver to peripheral tissues. Its composition is approximately 90% lipids and 10% proteins. VLDL-C contributes to lipid accumulation, atherosclerotic plaque rupture, and cardiovascular events, and elevated levels are linked to increased cardiovascular risk, particularly in patients with existing cardiovascular disease. Before reviewing two clinically important apolipoproteins featured on the CVMap profile, let's take a moment to review the general structure of lipoproteins. As you can see from this graphic, lipoproteins are composed of a combination of lipids and proteins and are synthesized in the liver and intestine. Lipoproteins contain a hydrophobic core composed of cholesterol esters and triglycerides, surrounded by a hydrophilic surface composed of apolipoproteins, phospholipids, and free cholesterol. It's this hydrophilic outer layer that allows lipoproteins to transport hydrophobic lipids such as phospholipids, triglycerides, and cholesterol within the hydrophilic environment of the body's systemic circulation. For perspective, the major types of atherogenic lipoproteins are shown here and include small dense LDL, triglyceride-rich lipoprotein remnants, and intermediate density lipoproteins. These lipoproteins are linked to an increased risk of coronary heart disease due to their association with development and progression of atherosclerosis, as well as other pathogenic mechanisms. Apolipoprotein B is an apolipoprotein produced in the liver that is attached to the phospholipid membrane of atherogenic particles. Each low-density lipoprotein particle contains one ApoB molecule, as do intermediate density lipoprotein and very low-density lipoprotein particles. Given that, the ApoB level represents the total number of circulating atherogenic lipoproteins. ApoB has been found to be superior to LDL-C and non-HDL-C in predicting CVD risk, especially in patients with diabetes or high triglyceride levels. As a result, a growing body of researchers have called for the inclusion of ApoB into consensus guidelines as a routine measurement alongside LDL-C to ensure the most accurate CVD risk evaluation and treatment effectiveness monitoring occurs. Lipoprotein A is a genetically determined atherogenic particle, which is composed of an LDL-like particle and a large distinguishing protein called apolipoprotein A. It's been found in numerous studies to be an independent risk factor for both CVD and calcific aortic stenosis. Given the ongoing emergent data related to this biomarker, numerous societies worldwide advocate for its measurement for a more accurate assessment of CVD risk. For example, the National Lipid Association recommends considering LPA testing for individuals with a significant family history of premature cardiovascular disease, in individuals with a personal history of premature cardiovascular disease, in severe primary hyperlipidemia, and to aid in shared decision-making for statin therapies. Canadian guidelines recommend universal screening for LPA, and the European Society of Cardiology suggests screening LPA at least once in a person's lifetime. Unfortunately, currently, there are no recommendations for testing pediatric populations. Apolipoprotein A has an interesting structure which consists of a series of tandemly repeated modules, known as kringles, that are commonly found in many proteins involved in the fibrinolytic and coagulation cascades, such as plasminogen and thrombin. And it's the number of ApoA's Kringle 4-like repeats that is genetically determined, with a fewer number of repeats resulting in a higher LPA level and vice versa. Finally, given its genetic determination, lifestyle interventions have not been shown to markedly change LPA levels, making optimization of all other modifiable risk factors in patients with elevated LPA crucial. Studies have also shown PCSK9 inhibitors to be an effective intervention, lowering LPA levels by 25 to 30% and reducing CVD risk in patients with markedly elevated levels. CVMap also includes a number of ratios that have been used clinically to provide additional insight into risk for CVD. First up is the total cholesterol to HDL-C ratio. A study published in 2022 looked at NHANES data gathered from 1999 through 2014 on a bit more than 32,000 participants, with a population composition of roughly 48% men and 52% women, all greater than 18 years of age. Researchers found increased cardiovascular mortality in individuals with elevated total cholesterol to HDL-C ratios. And in this study, increased CV mortality was noted for a ratio greater than 4.22. Numerous studies have shown this ratio to be a more significant CVD risk factor than either LDL-C or HDL-C, whether assessed alone or in combination. And in general, high ratios indicate increased cardiovascular disease risk, especially when above study-specific thresholds. The very low-density lipoprotein cholesterol to triglyceride ratio is valuable for assessing lipid metabolism, offering insight into lipid level responses to different treatment strategies. In general, a high ratio has been linked to abnormal lipid metabolism and increased risk for cardiovascular events. Studies suggest that the HDL-C to triglyceride ratio, sometimes reported in the literature as the triglyceride to HDL-C ratio, can identify individuals at higher cardiometabolic risk, especially in those at risk of developing diabetes. With Boston Heart's cutoffs, a lower HDL-C to triglyceride ratio correlates with increased risk for adverse outcomes, making it a useful complementary marker for assessing cardiovascular disease risk. Let's turn our attention now to cholesterol balance. The cholesterol balance test is exclusive to Boston Heart, and it's used clinically to provide insight into the major production and absorption markers for circulating plasma cholesterol. Clinically, this test is used to optimize levels of LDL-C and to monitor the subsequent LDL-C lowering response to current pharmaceutical and/or lifestyle interventions. Elevated lathosterol and desmosterol levels indicate cholesterol overproduction, and labs may show elevated levels of VLDL-C and LDL-C, especially in more common patient conditions such as obesity and familial combined hyperlipidemia. High beta-sitosterol and cholesterol levels indicate cholesterol overabsorption, and one of the most common causes of this is high dietary intake. Next up are markers of inflammation. We know that inflammation is the basic pathological process of most cardiovascular disease. In order to gain insight into the presence of inflammation at a systemic and vascular level, CVMap includes two markers of inflammation: high sensitivity C-reactive protein and lipoprotein-associated phospholipase A2. Elevated levels of hsCRP independently predict CVD risk, enhancing patient risk stratification and preventive strategy guidance, especially in individuals with normal lipid levels. Data suggests that serial measurements of hs-CRP are better than a single measurement for identifications of patients at higher risk for cardiovascular disease and heart attack. Numerous studies have confirmed the role of Lp(PLA2) as a significant biomarker of vascular inflammation, especially given its high specificity and low biologic variability. Lp(PLA2) seems to be closely correlated to cardiovascular events and may emerge as an important therapeutic target via medications that exert indirect lipid-lowering effects or direct Lp(PLA2) antagonistic effects. While both are biomarkers of cardiovascular disease risk, there's been some debate in the literature about which is the better biomarker. Some studies have shown that Lp(PLA2) is a better predictor of cardiovascular disease risk, especially in people with underlying risk factors such as high cholesterol and hypertension. Other studies have shown that hs-CRP is a better predictor of CVD risk, especially in people with diabetes or chronic kidney disease. Overall, it is likely that both hs-CRP and Lp(PLA2) are useful biomarkers of cardiovascular disease risk, and that the optimal value of either may depend on patient-specific risk factors and medical history. CVMap includes lipid particle number assessment as part of its comprehensive look at CVD risk, and in this final CVMap biomarker review section, we'll be touching briefly on each of these. First up is LDLP, an NMR measurement of the total number of LDL particles in serum. Now, this is a different diagnostic parameter than LDL-C, which is the measurement of the amount of cholesterol inside the LDL particle. Studies show LDLP is superior to LDL-C in predicting future cardiovascular events, especially in patients with discrepancies between concentrations of LDL-C and LDL particle number. LDLP is a strong, independent predictor of CVD risk, and therapeutic interventions to lower LDLP levels mirror both pharmaceutical and lifestyle management strategies that we previously discussed for managing elevated LDL-C levels. HDLP is an emergent biomarker that provides insight into the total number of HDL particles in blood. Low concentrations of HDLP have been associated with risk for coronary artery disease. Small LDLP is an emergent biomarker that provides insight into the total number of small, dense LDL particles in blood. Higher concentrations of small LDLP have been observed in individuals with metabolic syndrome. Large HDLP is an emergent biomarker that provides insight into the quantity of large HDL particles in blood. Data suggest a strong association between HDLP and risk for metabolic syndrome. And finally, large VLDLP quantitation provides the amount of large, very low density lipoprotein particles in blood, particles which are thought to be less atherogenic compared to small, dense LDL particles. Studies suggest that elevated levels of large VLDLP are associated with an increased risk for both coronary artery disease and cardiovascular disease. Now that concludes our overview of the CVMap profile. Thanks for joining me.
Thank you, Dr. Girman, for that informative presentation. Thank you all again for joining us for this webinar event. Until next time, from everyone at Avexia Diagnostics and Boston Heart, stay healthy, stay safe, and we wish you all the best on your pathway to wellness.